Bismillah ar-Rahman ar-Rahim. The topic assigned to me is gut-liver-brain axis in liver cirrhosis. So in the next 14-15 minutes, I shall explain to you what do we mean by the gut-liver-brain axis and what's its significance in a cirrhotic patient. The gut-liver axis refers to the bidirectional relationship between the gut and its microbiota in the liver. So this is the bidirectional relationship between the gut and its microbiota on one hand and the liver on the other hand. This reciprocal interaction is established by the portal vein, which enables transport of gut-derived products directly to the liver. So whatever products they are derived, they are carried to the liver, and the liver feedback route, the green one, of bile and antibody secretion to the intestine. So basically what happens in the gut-liver axis, that whatever is the gut and the microbiota products, the cytokines, the nutrients, and the microbial products, they are carried from the intestine to the liver, and there they has their impact, and then there is a feedback mechanism by the bile acid secretion and the antibody secretion, and the liver controls our response to the intestine accordingly. The liver obtains, we know, more than 2/3 of its blood by the portal system. We know that through portal vein, intestine-derived bacteria and their components can easily reach the liver. So this is fact, that the portal vein give an easy access to the bacteria and its components from the intestine to the liver. In the liver, bacteria can stimulate hepatic immune cells and thus activate inflammation pathways. So this is the pathophysiological way of role of gut-liver-brain axis in the liver cirrhosis patients. Gut microbiota colonizes in the outermost part of the mucous intestinal barrier. This is the mucous intestinal barrier, and in the upper part these bacteria reside. This mucous intestinal barrier is composed of 3 layers of defense. There are 3 layers of defense: the mucus, the epithelial cells, and gut vascular barrier. So the first is the mucus layer. The outermost part of the mucus layer contains the bacteria, but then the inner part, it is a sterile one. There are no bacteria in that. Then the second layer of this barrier is the monolayer epithelial cells, which is composed of enterocytes, goblet cells, tuft cells, and enterochromaffin cells. So this is the second layer of this barrier, which contains all these types of cells. And then comes the gut vascular barrier, the GVB, and it controls the systemic dissemination of microbial metabolites and the microbiota through the portal circulation. So it's a well set barrier having 3 components. The first one is the sterile mucus layer, the second one is the monolayer epithelial cells, and the third one is the gut vascular barrier. Cells in the second layer, that is the epithelial barrier, they protect the gut from insults arising from the microbiota and infectious agents by different mechanisms. There are different mechanisms how this second layer protect the gut from the insults. As I said, in the innermost layer are the of the gut, are the outermost layer of the mucus, and this is the lumen of the mucus. Here is the vessel. So here the bacteria are there, but how these bacterial microbiota are their products, they do not reach innermost by different mechanisms. And these mechanisms are physically as adjacent epithelial cells are sealed together by tight junctions. These are the tight junctions. So they are sealed very closely to one another. Electrically, as the brush border is negatively charged and opposes a negative charge on the microbiota. This is the brush border. This is the second mechanisms. The third mechanism is chemical mechanism, as a series of antimicrobial peptides are released by the epithelial cells. These epithelial cells, they release different sorts of antimicrobial peptides. Then mucosal immune cells, they patrol the epithelium and they are a defense mechanism against these microbial products. And lastly, the lamina propria, which is enriched in plasma cells that release IgA, and this further protects the barrier. So there are well set mechanisms how the second layer of this barrier, the defense against the microbial damaged particles. The gut vascular barrier, the third one, it controls the systemic dissemination of microbial metabolites and microbiota through the portal circulation. Thus, the intestinal barrier is therefore between the liver and the microbiota. It's the interface, and it is the functional and anatomical structure that serves as a playground for the interactions between the gut and the liver, limiting the systemic dissemination of microbes and toxins while allowing the nutrients to access the circulation and to reach the liver. This is the mechanism. Because of this disruption, there is the decrease in bile acids in the gut lumen, decrease intestinal motility, decreased gastric acidity. It leads to the altered gut microbiota and then the bacteria. There is a decreased pathogen associated morphological patterns. There is increase in secondary bile acids. All these leads to different mechanisms, and then there is sets of inflammation here. So if I summarize, there are two main abnormalities. One is altered microbiota, that the microbiota gets altered, and second is increased permeability of the intestine. And the intestinal barrier is disrupted at several places, like shown over here, and this leads to the translocation of inflammatory microbial metabolites and microbes which reach the liver and induce inflammation in liver injury. Liver is the first organ. We know that the liver is the first organ to encounter microbial products that cross the gut epithelial barrier, and thus it is affected by the gut microbiome ahead of any other organs in the body. Therefore, in end-stage cirrhosis, bacterial translocation probably plays a decisive role in different complications, including acute and chronic liver failure. The microbiota, the gut microbiota is of two types. One is the beneficial one. These are the important components of it. And another is the harmful one, the pathogenic one, and these are the components of pathogenic microbiota. Both of these they remain there, but the ratio is in favor of beneficial rather than harmful pathogens. The gut microbiome remains unchanged in stable outpatients. If it's a cirrhotic patient and stable, it remains unchanged. The ratio of pathogenic to beneficial taxa rises in decompensated cirrhosis, especially in patients with bacterial infection and encephalopathy. It means, like here in the healthy controls, this was the ratio. Then in the compensated, one almost normal. But in the decompensated and infected patients, the ratio got reversed. There were more pathogenic uh, microbiota as compared to the beneficial one. And this is the slides from the Bajaj who published recently. So, no, the role of gut liver axis is very much there in the liver cirrhosis patients. The microbial changes are widespread in cirrhosis, and not just the gut-liver axis, but saliva, blood, and skin. All these has shown that this microbial changes are there. The gut-liver is the mostly affected one, but we see the microbial changes generalized in cirrhotic patient. Gut microbiome uh, profiles differs in outpatients and inpatients and closely linked to outcomes in both scenarios. So the microbiome profile, it will be different in outpatients and in inpatients. Microbiota are associated with an altered gut-liver-brain axis, resulting in hepatic encephalopathy, cognitive function, and brain inflammation and edema are related to microbes in cirrhosis in hepatic encephalopathy. Microbiota can be used to exclude significant cognitive dysfunction in cirrhosis. So this is another role that we can do that. Ruminococcus and Clostridium in stool and saliva, they were associated with healthy cognition regardless of the testing modality. So the new tools which can help us the better management of cirrhotic patients. The altered macrobiota or the dysbiosis ratio, it also predicts hospitalization in outpatients. The microbial composition, it can predict the death, that which patients they are going to die, which patients they are going to develop the ACLF, which patients they will need ICU transfer, and which patients they will recover and there will be recurrence of the HE. So the microbial composition in any cirrhotic patient can predict these important clinical outcomes. So the story from healthy microbiota to cirrhosis-associated dysbiosis to gut bacterial translocation is caused by many factors. There are so many factors which leads to this dysrhythm. Abnormalities in microbiota composition and bacterial overgrowth are the hallmark of gut-liver axis disruption. These are the consequences of intestinal hypomotility, altered bile flow and composition, and impaired intestinal immunity. Gastric hypoacidity, favored by proton pump inhibitors, use or environmental factors such as a Western diet also contribute. So these are the additional contributing factors. In addition to this, there is damage to the epithelial and vascular intestinal barriers, which allows viable bacteria and pathogen-associated morphological patterns to enter the systemic circulation and result in the bad consequences. So, dear colleagues, we can conclude the paradigm on pathophysiology of cirrhosis has deeply changed. Decompensated cirrhosis is characterized by sustained pro-inflammatory and pro-oxidant milieu resulting from the systemic spread of pathogen-associated morphological patterns from gut and damage-associated morphological patterns from diseased liver. The deep alterations in the gut-liver axis result in translocation of pathogen-associated morphological patterns as well as viable bacteria, and the gut-liver-brain axis is the main player and decisive factor for the clinical outcomes of liver cirrhosis patient. So with this, I stop